We would like now to bestow this medallion on Dr. Michael Abramoff, the Robert C. Watzke, MD, Professor in Retina Research.
So first of all, I would like to spend only a few words on Bob Watzke. I've known him, and when I ask people around me about him, and the people I admire most, my mentors here, my guiding lights here in the faculty, what they say about you is that you're like a father to them, you were like a father to them, you were their primary mentor, and they have nothing but good things to say about you. Again, I haven't known you since yesterday night, but the fact that the people I admire most say these things about you means that you're sort of squared, amazing mentor. So thank you for that. And like I said, I don't want to give personal anecdotes about you because they wouldn't be mine, so I decided not to do that. However, I want to give two links. The first one was when I was a resident in the Netherlands in 1995, and I just started my first rotation. The first thing that I heard was the Watzke sign. So here I was, just out of internships. I learned a little bit about interactive ophthalmoscopy, but this Watzke sign was new to me. So the first name of anyone in ophthalmology was Watzke, and so I remember that to this day. And the other thing, which will, it's sort of a link between us, is you were central to the diabetic retinopathy study, the first major study of diabetic retinopathy. And you can see, for example, this paper is the sixth paper in 1981, so this is a long time ago. And what you were central in is publishing these papers, doing the whole research, but one of the things that remains is the slides that you see here. And these slides are in my office, and these slides are being digitized, and we use these today and in the future to make algorithms that read these images even better. So we already know how to do it, but we'll make them even better thanks to you and thanks to your role in this. So you wouldn't expect that, 30, 40 years later, we'll still be using those slides. So let me talk, since we're talking about diabetes and diabetic retinopathy, I will do things to link this to the donors, to you and to the donors who made this professorship possible. So one thing I want to talk a little bit about is how science works, and the other I want to talk a little bit about is how you can bring this science to the patients. So it's a very short vignette. I need about 8 minutes or so, 7 minutes. So in 1688 in Amsterdam, which I happen to know, and where I used to live, a textbook of anatomy came out by Steve Blankard. And it was in Latin. And so I happened to read Latin. And what it said on page 289 was Virgo aliquot ante obitum annus diabete correpta sunt. Paucus ante mortem diabus amorasi oculurum afficatur, adiot ut solis aut candelae luminant admine verterret. And what this means, if I translate it, is a young girl suffered from diabetes for almost a year. Before her death, she suffered from blindness in both eyes, and she could see the light of neither sun nor candle. And this is the first time anyone ever mentioned that the link between diabetes and visual loss and blindness. So before, the Greeks even knew about diabetes as a disease, but they didn't know that it could blind you. And so this is the first description. And I want to get back to this. How do I get back? Okay. So I wanted to mention about this picture that is in the book, that it was at that time bedside to bench. So everyone is now talking about bench to bedside, right? You move your science to the patient at the bedside. But here you can see how in these anatomic laboratories, they were waiting for the patients to die. So you see a patient with the first red arrow on the right, and then this patient had diabetes, so that's why looking at the urine, even though they didn't know exactly what was going on. But as soon as you were dead, or a little bit before it even, you ended up on the table, and they would cut you open. And so what then happened was mortua crania aperto insignis vesica aquaso inventa est. And again, translated, her skull was opened, and it was still warm, and we discovered a fluid-filled region which prevented the light from entering the optic nerve, because at that moment we still thought that light went through the optic nerve into the back of the brain to be seen, to perceived. So this was the first mention. So now people had done research about visual loss in diabetes and whether it was vascular or neural. And Labour, well known to all of us, wrote a textbook in 1875 about diabetes in the eye. At the same year, in 1875, Mr. Howship Dickinson in London wrote a textbook on diseases of the kidney. And you would think, what has the kidney to do with this? And so this is in German, which I happen to read. And it says, was liegt näher als die Vermutung, dass ähnliche Prozesse Herde von kapillären Blutungen wie sie in ihr Netz haut, nach Analogie der Histologie genau erforschten Befunde bei Morse's Brighty angenehm. And what this means in translation, if what is more likely than that these similar processes, capillary hemorrhages and vessel changes, affected nerve cells in the retina and the nervous system. So he saw clearly vascular changes come first, and then the nervous system and the retina are damaged later. However, Dickinson, the same year, was saying they are such indeed as to link symptoms with lesions and to give diabetes a definite place among diseases of the nervous system. So then his entire book was about diabetes as a nervous disease, later causing all these other changes. Well, it's called Publish and Perish. So Dickinson, everyone forgot about this, and then Mackenzie in 1879 cited both Dickinson and Labour, and he said, to my mind, all of this, the changes in the nervous system and those in the retina and the other organs are due to an altered condition of the blood and the blood vessels. And from then on, everyone in diabetic retinopathy has been citing Mackenzie. Friedenwald, 1950, Kogan, 1961, all the main authors of diabetic retinopathy, both in animal models and in humans, cite Mackenzie, and no one ever thought again of Dickinson. And so this year, Dr. Sohn, who's in the audience, and me published this paper on showing essentially that diabetes damages the retinal first after all. So the damage in the nerve cells comes first, and then the vascular changes happen later. Whether they cause it, we don't know yet. We're trying to find out now. But the point is that 150 years later, everything can change. And what I wanted to say is, how can we do this? Well, Keith already mentioned it. What I do is really develop computer algorithms to analyze retinal images. So what we see as retinal doctors, I analyze and then quantify, and I'm showing you some example of this, how this works. It's much too much. It's almost 250 papers. So I'm not going into that, but it's sort of a colorful representation of all these things that you can measure and quantify in the retina. And that made possible this paper where we showed, like I said, that the nerve damage comes first. So this has lessons for this professorship as I see it. I think it will be science that is settled until it's not, and we'll be doing a lot of that. So there will be no safe spaces here. It will really be science that may challenge existing paradigms, and hopefully that's better for patients. And I say hopefully, because this will do wonders for my H-index. And if you don't know what an H-index is, it's sort of a combination of citations and publications, the number of citations and publications, and it's really a metric for scientific productivity that we as scientists are judged upon. I consider myself a physician first and then a scientist. So I think there should be something, I'm not saying it should be exactly what I say, a P-index, which is related to how important it was for patients, divided by the number of patients, because obviously if you do something for a less prevalent disease, you can still make very important contributions. And so I'm not saying it's about the number of patients to touch. There's this ratio, just so I don't get comments afterwards. And so the other thing is really impacting patients. And how do you do that? Do you just publish papers and then it happens, like this PNES paper I was mentioning a few slides ago? So we published it this year. Does it affect anyone in clinical practice? No. Sometimes, like with Dr. Watzke's studies on the DRS, it really impacted clinical care very quickly. But those days are over, I think. And so how do you bring something from science to the patient? Well, let me give you a personal example. Different subject, having to do with diabetic retinopathy. In 1989, I started studying machine learning using artificial neural networks, like mimicking the brain in a computer. And I went to slide too far, sorry. I published a paper in 1991, and here's me presenting that to a skeptical audience. And that hasn't changed much. And so in 2000, I was just in fellowship, and I did my first paper on screening for diabetic retinopathy lesions and detecting these with the computer. And so, no patient was touched by this, no one picked it up, because I thought, you do a few publications that it can be done, because no one knew at the time it could be done, and then everything will change. That didn't happen. So I did many more papers, nothing changed. From 2000 on, I started publishing real clinical studies and clinical trials in actual patient populations. Many more papers, nothing changed in clinical practice. So clearly it's not enough to publish papers. So I thought maybe you need to do patents, because then patents and a company will pick it up and they will commercialize it and it will happen. Well, I did, it's more than this, but on the retinopathy it's like 7 patents. There's some on the cameras, so I won't go into that. But there's at least 7 patents on this subject. Nothing happened. So what you need to do is found this company, and I'm really proud to bring this up. So this is IDX, with a couple of spouses there, but this is IDX, the company here in Iowa City, and we founded that to commercialize these inventions and these publications and this science. And I will show you a demo because it's so cool. So this is how it works. If the video comes up, because it worked this morning. No video? Oh, here we go. So this is not FDA approved. It's used in Europe, but it's not FDA approved. But it just shows you how this is going to work and what the future of at least the retinal exam for diabetic retinopathy is. So here's a patient. This camera is fully automatic, so you press a few buttons on the screen and it starts to find the pupil and the eye and does the protocol as it should, as you can see here. So there's minimal interaction, so you don't need certified ophthalmic photographers. You can just do someone who taught a course for 2 hours. So look how this robotic camera finds the other eye, zooms in, focuses. Everything is automatic. You just need to press the start button to take the picture. And then the big thing comes where we select these images, we run the algorithm, and it's faster now. It's less than 90, it's more like 60 seconds. So in a few seconds we speeded this up. It's a diagnosis. So this can be diabetic retinopathy detected or no diabetic retinopathy present, which is all you need for a diabetic retinopathy exam. So these are the different outputs that it can get. So this is happening now. So it's a first, right? I mean, no one has ever done these automated algorithms, which essentially replace what a dilated eye exam does for screening for diabetic retinopathy. But one day, and hopefully soon, the FDA will approve this, and then we'll be seeing it in clinical practice. But again, the FDA has not approved this. So this is what it takes, and we're not even there yet because the FDA has not approved it yet. What it takes to move something from science to actual where it touches patients. So it's a lot of time, it's a lot of effort, it's a lot of people. I could never do this on my own, ever. There's so many people in IDX and around it. And so I want to say that if the Robert Watzke Professorship for me was a success, my P index should be increased faster than my H index. So it's great if I do more papers and more scientific papers, and I think it's really important. But if it didn't affect patients, I don't think I was a good candidate for the professorship. So with this said, so you have you can judge me now on a metric, and I like that. I like to be judged on metrics, and I think that's good. But more importantly, I want to thank everyone for this great honor, specifically Keith, who made this happen, Ed, who helped a lot with this, Bob Watzke for being here, and Bruce Pfeiffer for saying a few words about later after me. For everyone in the faculty, there's always a friend and colleagues, and they're so helpful. It's such an amazing, I love this place, I have to say, I love this place. Everyone in the staff, too many people to mention, the people in IDX, of course. I thank you again. Thanks so much.